HIV. The models that I'm talking about are these four. The first model is looking at integrating HIV services into family planning in Kenya. So this works primarily from the family planning service delivery point and bringing on the HIV counseling and testing services, HIV care, treatment, and cervical cancer screening as part of the services. And we all know that women living with HIV are at a higher risk of cervical cancer. The second model is looking at integrating services into postnatal care and family planning in Kenya and Swaziland, focusing mainly on public health facilities in these two countries. And as I said earlier, again, the drive for this is that is often a subpopulation that is neglected. So we're looking at integrating HIV counseling and testing and HIV care and treatment into postnatal settings and looking at the various factors that determine the success of those services. The third model looks at integrating HIV and sexual reproductive health services. And this focuses mainly on the IPPF member station clinics in the three countries. And this is informed by the fact that IPPF was primarily a sexual reproductive health organization. And now, because of the needs of the clients, it has become necessary to bring on board HIV services to be able to meet all the needs of the clients. And this last model is the conversion of integrated and standalone services in Swaziland, which really looks at some of the client perspectives in terms of what kind of services do clients prefer and for what reasons, and to a large extent looks also at stigma issues. But for the purposes of this presentation, we'll be focusing on these two models, Model 1 and 2 in Kenya and Swaziland. What are the key questions that this work aims to answer? The first one is the relative benefits of the various models. Just looking at it, does the clientele increase owing to integration? Does the clientele profile change? Do we have more male clients taking up services, for instance? And does the quality of services increase? And as we go along, you'll be able to get information on what is happening on the ground as a result of this work. In terms of the target populations and the risk of HIV, we are looking at, does HIV-related risk behavior change over time because of integration of services? How does it affect stigma? And what is the contribution to unintended pregnancy, to address the issues of unintended pregnancy? But importantly, for policymakers in here and out there, for those of us who are aiming at advocacy work, what is the cost and feasibility, as well as cost effectiveness and the cost efficiencies of integrating these services vis-a-vis providing the services in a vertical manner? So, to what extent can you integrate cost effectively? Those are some of the questions for us. So, and the interventions that we are working on are listed up there. It is looking at the infrastructure, the capacity, the skills, and the space aspect of them, as well as the guidelines. I take this opportunity to welcome my colleague, Charlotte Warren, who will take it up from here. Thank you.
Thank you very much. Thank you very much, Dr. Teba, for that introduction. So, as Dr. Teba has alluded there, looking at the principal models that we're looking at. So, please interrogate the models and have your questions later on. I'll go ahead and introduce Charlotte Warren. Charlotte Warren is from Population Council. She's a lead scientist in maternal and newborn health with a wide experience in public health. She's currently the principal investigator for the Integra Initiative and has worked in Kenya and Swaziland and a PI for the Kenya evaluation of vouchers for reproductive health.
presentations, and most of them are covering evidence from the local studies. These results have been presented at small examinations in Swaziland and Kenya earlier this year, late last year. So I'm just going to run through the data collection activities that we've done over the last 4 years. So it's divided into 3 main areas. We have health facility assessments in 12 facilities in Swaziland and about 27 facilities in Kenya. So we did the usual health facility assessment, we looked at the inventory, the statistics, we looked at the observed, the consultations, and these were linked with exit interviews, and we had in-depth interviews with clients and providers. And then we also did an economic study looking at the costs and efficiencies of integration as opposed to vertical services. We also followed women over 2 years, and we recruited them from the family planning clinics or the postnatal clinics, depending on the model. So the family planning was in Kenya, and the postnatal was in Kenya and Swaziland. And we followed them up over clearly about 25 months from recruitment. And then we also have community research where we went to do a household survey around the facilities in the family planning model in the Central Province in Kenya and around Manzini in Swaziland. For the cohort, it was a cross-sectional prospective survey, and the facilities were assigned to intervention comparison groups. The women for the postnatal model were 0 to 10 weeks postpartum, and we recruited those specific public health facilities. And the family planning cohorts were recruited from public family planning clinics in Kenya. And they were identified using consecutive sampling, and the analysis was done on periodic. So just for background in Swaziland, we know that there's a high HIV prevalence. The DHS in 2007 was 26%. And the HIV prevalence among pregnant women is around 42%. We have a very high antenatal attendance, at 97%, and a number of women do attend for deliveries in facilities, but the postnatal attendance is quite low. So for this particular presentation, I'm using the data from the recruitment of the cohort and comparing it by HIV status. We had about 44% of women reported that they were HIV positive in this group, and the number of HIV positive women was about 386, and HIV negative women was 453. So you can see that the HIV positive women were older by 2 years compared to the HIV negative women. And then we also found that there was a higher parity among HIV positive women, but that's probably due to the fact that they were older. We found that over 2/3 of the postpartum women said that the most recent pregnancy that they had just delivered was unintended. And then we divided this between whether it was unwanted, or they didn't want to have a child, or whether it was mistimed and they would prefer to wait till later before having that pregnancy. And you can see that HIV positive women were more likely to not want the pregnancy at all, whereas the mistimed pregnancies, HIV negative, were higher. And although these women were interviewed within 10 weeks of giving birth, you can see that a very high proportion of women do not want to have a child, and this was significantly different among the HIV positives. Now we do know in other studies when you interview women at postpartum period that they just had a baby, so the thought of having another baby too soon is off-putting. But if you ask them again in 6 months, then the intention does change. So we also asked, for the most recent pregnancy, what the methods they were using to try and see if there was inconsistent use or gaps in the services provided. And we can see that significantly more women, HIV-positive women, who were using a family planning method before they became pregnant, then became pregnant, you can see that male condoms were used, 2,000 women using male condoms, followed by the injectables. So we can see that maybe these were recruited in 2010, so maybe condoms was the preferred, or the one that was providers were saying you must use a condom, and yet if there's inconsistent use, then it failed to prevent pregnancy. Methods received during the most recent visit, or the current visit, you can see that injectables were the most commonly available, followed by hormone pills, and then male condoms were more likely to be used among HIV-positive women. So do postpartum women have an unmet need for family planning? We found that the majority said they were breastfeeding, and and they were exclusively breastfeeding, but significantly more HIV negative women were exclusively breastfeeding. More than a third had started family planning, and 1/5 had resumed sexual activity. 2/3 of the women who had resumed sexual activity were breastfeeding, and 28% were using family planning and several breastfeeding. So they may not have an unmet need at the moment. There was a few women who were not breastfeeding nor using family planning, so they're obviously at risk of pregnancy sooner than maybe they want. So at the moment they don't have an unmet need, but as the months progress, and especially around the 6-month period when they start reducing exclusive breastfeeding, then there's a risk of becoming pregnant. So we saw that the demand for family planning is high in Swaziland. It's higher than in other countries. It's higher than in Kenya in this postpartum period. But there were high unintended pregnancies for the most recent pregnancy. Most women do not want more children, but there are limited choices of pregnancy methods available. I think there's only one woman who got a 90-year postpartum period. So they're using the same methods that they used before they got pregnant, pregnancy, and they're using the same method now, and yet they don't, a huge proportion do not want to have a child. And we saw that a lot of women had either previously started family planning or they received the family planning method in this current visit. So from a recommendation coming out of that is that perhaps that more health workers need to be able to provide implants and other long-acting methods to postpartum women to meet a large unmet need for both basic limiting and reduce the likelihood of future unintended pregnancies. Thank you.
Thank you very much, Charlotte, for that talk. The next speaker is Dr. James Kimani. Dr. James Kimani is a senior analyst in the reproductive health program at Population Council. He will present the paper on the effect of postnatal care and HIV integration model on uptake, provider-initiated testing and counseling, and family planning services among postpartum women in Kenya. Thank you.
Good afternoon. I'm going to try not to bore you or put you to more sleep because I'm sure everyone has eaten very so I'll try to make it short, quick, and exciting, I hope. So I'm going to present to you results for the model on postnatal care and HIV integration. And specifically, I'll be looking at the uptake of provider-initiated testing and counseling and family planning services among postpartum women in Kenya. So a little bit of background. We know for a fact that postnatal care is usually neglected by the health system. We know that postnatal needs for new mothers, especially in sub-Saharan Africa, they are not well taken care of by the system. We also know that we have evidence on ANC services in terms of access, use, and also as well as the delivery services from various services, including demographic health service. But when it comes to postnatal care, we know that gaps are there, and these ones are mainly on issues of timing. When is the best time for a woman to get postnatal services, and the baby also. The content mostly focus on the baby alone, looking out the woman, as well as issues of linkages to critical services, especially family planning and HIV. As well, because of these gaps, we know that new mothers might be left out from accessing critical services that are needed for their survival in some cases, because we know that more than 60% of maternal deaths occur during the early postpartum period. So it should bring alarm bells to everyone that we should focus on that period, because it's a very vulnerable and critical period for new mothers. So my study was trying to look at, or to assess, how effective it is to integrate postnatal care and HIV services. And now I'm looking at providing initiated testing and counseling and family planning. So a little bit of the methods. These are women who are assigned to intervention and comparison groups, and they had given birth within the previous 0 to 10 weeks and were still postnatal care. So these are the women who we recruited for this particular study. And for this particular analysis, I'm looking at the recruitment data, which is baseline, and follow-up later on, at 15 months after the project was implemented. Then I'll touch a bit on descriptive statistics, and we did a bit of multivariate analysis so that we control for confounders as well as clustering effects because of the women recruited facilities. So we need to take care of those bias that might come because of the clustering at that level. So a bit of the results. Probably should give you the sample sizes a bit. For the recruitment round for intervention, we had 815, and at 15 months we had 573 women. And then for comparison, at recruitment there were 878. I'm sure it's not on the screen, but I have to give you the figure. And then at round 2 we had 631 women who we followed up. So a bit of the results, as you can see from the screen, the green bars, those are intervention, women who went to the intervention sites or facilities, and the red bars for the comparison. So you can see from baseline, there was significant improvement in terms of the proportions of women who are offered PHC at the visit, from 15% to 46, or about 47%. That would be a change of about 31 percentage points. So you can see there was a big jump in the intervention activities as well as in the comparison. So to be able to test whether these proportions mean anything in terms of are there any other influences or confounding factors, the table I want you to focus mostly on the last two rows, what we call differences, but it's looking at the changes before and after for the intervention group and the same for comparison. And then you get the differences. That's where you see the percentage points of 11.6. So that's a positive number which says that the change was positive or significant, positive in the intervention sites. However, we're looking at the odds ratio. This is now the multivariate after accounting for other confounding factors as well as clustering. We see that the magnitude of change is in the positive direction in terms of meaning that the change was greater in the intervention sites. However, this was not statistically significant. Looking at other characteristics or factors that we control for, we find that type of facility influenced the uptake of PHC. Women who went to health centers, they were more likely to be offered PHC compared to those who went to hospitals. Partner status was also critical. We see that women who say their partners have been tested are more likely to be offered PHC. There are issues of equity. We see that poor households or women from poor households were less likely to receive PHC. There was also influences from education. Interestingly, people or women with secondary education were less likely to have been offered compared to those with primary or no education. Age was also a factor. We find that women who are 35 years and over were more likely to be offered PhD compared to 15 to 24 years, or mothers who are within that range. The next result on family planning, uptake or use, we see that there's also greater changes between baseline and round 2 for both intervention and comparison. We see for intervention it moved from 7% to about 76%, which is a jump of about 70 percentage points. So looking at what type of method they received, we see that most women were receiving short-term methods, and the most popular one is injectables. And then looking at round 2 to see whether there was any change between baseline and round 2, we find that long-term methods and permanent methods increased in the intervention sites, meaning that there was some effect from the intervention activities in terms of increasing the proportion of women who are using those methods. And for long term, the most popular one was implants that the women said they were using or they received at the current visit. Looking at the multivariate analysis again, the last 2 rows you see that the percentage points shows that the magnitude of change was positive for intervention sites. Controlling for other factors or confounders, we see that the magnitude of change says that in the intervention sites it was greater than comparison. However, those differences were not statistically significant. Looking at other characteristics, we see that type of facility, health centers, or women who went to health centers or dispensary were less likely to receive or use an FP method. And being single was also associated with less probability of being or receiving or using an FP method. So what does the studies or the findings tell us? In a nutshell, they show that integration of PNC and HIV services worked, because you've seen that the proportion of women who were offered PHC and FP services increased in the intervention sites. There was also a significant increase in the proportion of women who received long-term and permanent methods in the intervention sites. However, at the multivariate level where we control for other confounders, although the magnitude of change was greater in the intervention sites, we see that that change was not statistically different between the intervention and comparison. Type of facility, partner status, HIV status, age were associated with the increased uptake of PHC. However, if you are poor and secondary education, you had low probability of getting PHC. Women who are visiting lower level facilities, health centers and dispensaries, and single mothers were less likely to receive use of family planning methods. In conclusion, the studies findings suggest that an integrated approach in the delivery of postnatal services is beneficial to increasing HIV counseling and testing and family planning services among